Welcome to the Deep Dive. I'm Harvey, and with me today is Donna. We're both experienced MCCQE reviewers,
That's right.
and we're here to help make this whole exam review process a little bit easier for you Canadian medical students out there.
Absolutely. Think of us as your study buddies,
Yeah,
guiding you through all those major concepts you need to know to conquer the MCCQE.
exactly. And we'll be drawing on reliable sources like stat pearls, breaking down complex topics, and just making sure you really get it.
Yeah, we're diving deep into tachycardia today, a topic that you're pretty much guaranteed to see on the MCCQE.
For sure. And before we jump in, just a quick reminder, this is for informational purposes only.
Yes.
It's not medical advice.
Absolutely.
Always consult a qualified healthcare provider for any health concerns or before making any decisions related to your health or treatment.
Okay, so let's get to the heart of the matter.
All right.
What exactly is tachycardia?
Yeah, it makes you think of like a runaway train or something.
It does.
But really, it just means a heart rate that's faster than normal.
Right. And the key to understanding tachycardia is knowing that there are different types.
Oh,
Think of it like a tree with branches. The main split is between
fine.
supraventricular tachycardia starting above the ventricles and ventricular tachycardia originating within the ventricles.
So supraventricular of the ventricle.
Right.
Ventricular right in those powerful pumping chambers.
Exactly.
Okay, I can see how that distinction would be important.
Yeah.
But how do we tell them apart in a clinical setting? Is it all about the symptoms?
Symptoms can offer some clues, but the real MVP here is the electrocardiogram,
Oh, wait.
the ECG.
The ECG, our trusty tool.
Yes. It's our window into the heart's electrical activity.
So we can see the heart's electrical signals laid out right in front of us.
Exactly. One key feature we look at is the QRS complex. Imagine it as the electrical signature of the ventricles contracting.
Okay.
In supraventricular tachycardia, the QRS is usually narrow because the signal's following the heart's normal pathways.
Okay, so a narrow QRS means the signal is moving along smoothly, like a car on a well-paved highway.
Perfect analogy.
Okay.
But with ventricular tachycardia, the signal originates in the ventricles themselves,
Okay.
taking a detour, creating a wider QRS complex on the ECG.
Ah, so wider QRS complex is like a roadblock,
Yes.
signaling something unusual is happening down in the ventricles.
Exactly.
Makes sense. Are there other clues we can find on the ECG?
Absolutely. The P wave is crucial too.
Okay.
It represents the atria's electrical activity,
Mm-hmm.
the top chambers of the heart.
Okay.
The P waves shape what we call its morphology,
Okay.
and its timing relative to the QRS complex can give us vital information.
Okay, so we're looking at the P wave for information about the atria's electrical activity.
Yes.
Is there an easy way to visualize this, an analogy perhaps?
Think of it like a relay race. The P wave is the first runner, the atria,
Yeah.
passing the baton to the second runner. The ventricles, represented by the QRS complex.
Gotcha.
The timing between them is crucial for a smooth race. And any hiccups can signify trouble, for instance. In a common type of supraventricular tachycardia called AVNRT,
Yep.
the P wave can be hidden within the QRS complex, almost like the first runner jumping onto the second runner's back to cross the finish line together.
Wow, that's a great way to picture it. So we're not just looking at individual waves, but also their relationship, their timing. It's like a carefully choreographed dance, and any misstep can throw off the rhythm.
Precisely. And once we understand the type of tachycardia,
Yeah.
we can start investigating its root cause.
Okay.
And that's where things get really interesting because the causes can be quite varied.
Right. From benign things to more serious conditions, I imagine.
Exactly. It's like solving a medical mystery,
Mhm.
piecing together the clues from the ECG,
Yeah.
the patient's history, their lifestyle, and everything
Yeah.
else.
So I'm curious about one specific type of supraventricular tachycardia that you mentioned earlier.
Yeah.
AVNRT. It stands for atrioventricular nodal reentrant tachycardia. Can you break that down for us? That reentrant part sounds a little intimidating.
Okay, let's demystify reentrant. Think of it this way. Imagine a racetrack with two lanes.
Okay.
Normally, the electrical impulses in the heart travel down one lane, a smooth, straightforward path.
Gotcha.
But in AVNRT, there's an extra lane within the atrioventricular node.
Okay.
A detour, if you will.
So two pathways instead of one.
Right.
I'm seeing where this is going.
The electrical impulse gets trapped in a loop between these two pathways,
Okay.
circling around and around, causing the heart to beat too fast.
Gotcha.
That's the reentrant part. The signal re-enters the same pathway,
Okay.
causing a rapid repeating cycle.
Right.
It's the most common type of PSVT,
Okay.
paroxysmal supraventricular tachycardia.
PSVT. Now that paroxysmal part also sounds a bit daunting. What does it mean in this context?
Paroxysmal simply means sudden onset and termination.
Okay.
Or like a sudden burst of speed, then back to normal.
Okay.
People with PSVT can experience these rapid heartbeats out of the blue.
And they can be quite alarming.
So it's not a constant thing.
Right.
It comes and goes in episodes.
Exactly.
No wonder it can send people to the emergency department.
Absolutely. And it's important to remember that PSVT can affect people of all ages.
Right.
Even those with no underlying heart problems.
Wow.
That's why understanding the different types and their characteristics is so important.
Okay, this is fascinating. It's amazing how such a tiny electrical glitch can cause such noticeable symptoms.
Right.
So we've got AVNRT.
Yes.
The most common form of PSVT,
Yes.
involving those reentrant circuits in the AV node.
Mm-hmm.
What are the other types of PSVT?
Another one is AVRT,
Okay.
or atrioventricular reentrant tachycardia. This time, the extra pathway isn't within the AV node itself, but outside of it,
Okay.
creating a larger circuit for the electrical impulse to travel along. Imagine a longer, more winding racetrack.
Okay, so a bigger loop for the electrical signal to get stuck in.
Exactly.
And just to clarify, AVRT involves an accessory pathway, one that's not typically there in a healthy heart. Exactly. It's like an extra electrical shortcut that shouldn't be there.
Right.
And there are two forms of AVRT orthodromic, where the impulse travels down the AV node and back up the accessory pathway,
Right.
and antidromic, which is less common, where it goes down the accessory pathway and back up the AV node.
So it depends on which direction the electrical signal travels.
Exactly.
Fascinating how these subtle differences can have such a big impact. Is there a third type of PSVT?
Yes, we have focal atrial tachycardia, where the rapid rhythm originates from a single spot in the atrium.
Okay.
Almost like a rogue spark setting off a chain reaction.
Gotcha.
This type can be seen in healthy individuals, but can also be associated with structural heart disease.
Yeah.
It's important to remember that each type has its own quirks and clues on the ECG.
Okay, so we've got our three main types of PSVT. AVNRT, AVRT,
Yes.
and focal atrial tachycardia. Each one has its own unique electrical signature, and it sounds like interpreting those ECG findings is crucial for making the right diagnosis. What are some of the key things we should be looking for when we're analyzing the ECG during a suspected PSVT episode?
First, we check the heart rate,
Okay.
which is obviously going to be fast in tachycardia. Then we scrutinize the QRS complexes in narrow or wide. That helps us distinguish between supraventricular and ventricular tachycardia right off the bat.
Yep.
Then we look at the P wave,
Okay.
its shape, size, and whether we can even see it.
Right.
In some cases, it might be buried within the QRS complex,
Oh, wow.
making it tricky to spot.
So it's like a detective game piecing together all those clues to figure out what's really going on with the heart's rhythm.
Exactly. And sometimes comparing the ECG during the tachycardia episode to a baseline ECG, if available,
Okay.
can be incredibly helpful. It's like having a before and after picture to see what's changed.
Right.
And in some cases, an electrophysiology study is needed.
Yeah.
This involves threading catheters into the heart to map out the electrical pathways, providing a detailed roadmap of the heart's electrical system.
Okay, so those are some of the tools we use to diagnose PSVT.
Yes.
And once we have a diagnosis, we can start thinking about treatment,
Yeah.
which I'm guessing depends on the specific type of PSVT and the underlying cause.
Exactly.
But before we dive into management, I'd love to shift gears and talk about another major branch of the tachycardia tree,
Okay.
ventricular tachycardia, or VT. What makes VT stand out from its supraventricular cousin?
Ventricular tachycardia is a bit more serious.
Okay.
And it demands prompt attention. Remember, it originates in the ventricles, those powerful chambers responsible for pumping blood out to the body.
Right.
Any disruption down there can have significant consequences.
That makes sense. It's like having a glitch in the heart's main engine,
Yes.
which can really compromise blood flow.
Right.
And I'm guessing VT is more likely to be associated with underlying heart disease
Yes.
compared to PSVT, which can often occur in healthy individuals.
You're absolutely right. VT is often a red flag,
Oh.
signaling something more serious is going on.
Gotcha.
Just like with PSVT, there are different flavors of VT, each with its own set of characteristics and implications.
Okay, I'm eager to learn more about these different types of VT and what makes them tick. But before we go there, could you walk us through the main differences between sustained and non-sustained VT? I remember reading something about that, but I could use a refresher.
Of course, think of it like This sustained VT is the marathon runner,
Exactly.
lasting for more than 30 seconds,
Mm-hmm.
or requiring intervention because it's causing the patient to become unstable.
Okay.
It's a cause for concern because it can compromise the heart's ability to pump blood effectively.
Okay, sustained VT, the long-distance runner that can really wear down the heart.
Yeah.
And what about non-sustained VT? Is it more like a quick sprint?
Exactly. Non-sustained VT is the sprinter.
Okay.
Short bursts of rapid heartbeats lasting less than 30 seconds.
Okay.
While not as immediately concerning as sustained VT, it can still be a sign of underlying problems and warrants further investigation.
Oh.
Think of it as a warning sign that something might be brewing.
Got it, sustained. VT is the marathon runner, a cause for immediate concern, while non-sustained VT is the sprinter, a potential warning sign that we need to pay attention to.
Precisely. And just like with any good mystery, understanding the characters, the different types of tachycardia is just the first step.
Right.
We need to dig deeper to uncover the underlying plot, the causes behind these rapid rhythms.
And that's where we'll pick up in our next segment, right?
Yes.
Delving into the common causes of both PSVT and VT and exploring how those factors influence our approach to diagnosis and management.
Exactly.
I can't wait to unravel those mysteries.
You and me both stay tuned, everyone, because things are about to get even more interesting.
Welcome back to the Deep Dive. We're delving deeper into the world of tachycardia, exploring the causes behind those rapid heartbeats and how understanding those causes shapes our clinical approach.
That's right. Remember, we're like detectives here,
Yeah.
piecing together the clues to solve the mystery of what's driving these heart rhythm disturbances.
Exactly. You mentioned earlier that the causes of tachycardia can range from benign to serious.
Sure.
What are some of the most common culprits we encounter in clinical practice?
Well, let's start with PSVT, paroxysmal supraventricular tachycardia.
Okay.
Sometimes it's triggered by simple things like stress,
Okay.
caffeine, or even certain medications.
Okay.
Dehydration and electrolyte imbalances can also play a role.
Okay. So those are things that can temporarily disrupt the heart's electrical system.
Yeah.
What about more persistent or structural causes of PSVT?
In some cases, PSVT might be linked to underlying heart conditions
Right.
like Wolff-Parkinson-White syndrome, where an extra electrical pathway between the atria and ventricles
Mm-hmm.
can lead to those reentrant circuits we discussed earlier.
Right. Those extra pathways can really throw a wrench into the heart's electrical system.
Exactly.
Now, what about ventricular tachycardia or VT? What kind of detective work do we need to do there?
With VT, the stakes are often higher. Ischemic heart disease, where the heart muscle isn't getting enough blood flow
Right.
due to narrowed or blocked arteries, is a major player.
So a heart that's been damaged or weakened is more susceptible to developing VT.
Exactly. And cardiomyopathies,
Okay.
diseases of the heart muscle itself, are another common cause. These conditions can affect the heart's structure and function, making it prone to those erratic rhythms.
Cardiomyopathies, that sounds like a whole other deep dive. Are there different types of cardiomyopathies we should be aware of?
You bet there are several types, each with its own set of characteristics and implications. Dilated cardiomyopathy, where the heart chambers enlarge and weaken, is one example. Hypertrophic cardiomyopathy, where the heart muscle becomes abnormally thick,
Okay.
is another. And then there's arrhythmogenic right ventricular cardiomyopathy, where the muscle tissue in the right ventricle is gradually replaced by scar tissue.
So many different ways the heart muscle itself can be compromised and increase the risk of VT.
Right.
It's like a whole cast of characters contributing to the plot.
You're right. And don't forget about those inherited channelopathies we talked about earlier.
Right.
These are genetic conditions that disrupt the heart's electrical system, and they can be a significant risk factor for both PSVT and VT family history, is a big clue in these cases.
Right, so we've got ischemic heart disease, cardiomyopathies, inherited channelopathies.
Yeah.
It's like a whole web of potential triggers for VT.
Exactly.
And I'm guessing other factors can tip the scales as well.
Absolutely. Electrolyte imbalances, drug toxicity.
Yeah.
Even certain medications can sometimes contribute to the development of VT. It's like a complex recipe, and sometimes it's hard to pinpoint the exact ingredient that's causing the problem.
Okay, so lots of potential culprits to consider.
Yeah.
It sounds like taking a thorough history and doing a comprehensive physical exam are even more crucial when we're dealing with tachycardia.
You bet we need to be thorough detectives. Gathering as much information as possible to understand the context of those rapid heartbeats.
Right.
Are there any red flags in the patient's medical history, family history of heart problems, any medications they're taking that could be contributing?
Yeah.
It's all about connecting the dots.
Right. Every detail could be a clue.
Right.
And I'm guessing certain symptoms or patterns might point us in a particular direction.
Absolutely. For instance, if someone with a history of coronary artery disease presents with sustained VT and chest pain, it raises serious concerns about potential heart attack.
Right.
But if a young, healthy person comes in with brief episodes of PSVT triggered by stress or caffeine, it paints a different picture.
So it's not just about the tachycardia itself. It's about the whole clinical presentation.
Exactly.
The patient's story. And of course, the ECG is our trusty sidekick.
Yes.
Helping us decipher those electrical signals and guide our detective work.
Precisely. The ECG provides those objective data points. Yep. While the history and physical exam help us understand the narrative, the context surrounding those rapid heartbeats, it's a collaborative effort blending art and science.
This is all starting to make a lot more sense. Now, it's not just about memorizing facts.
No.
It's about applying those facts to real-life scenarios, understanding the nuances, and piecing together the whole puzzle.
Exactly.
I'm starting to feel like a real tachycardia detective.
That's great to hear. And remember, the MCCQE is all about applying knowledge, not just regurgitating facts.
Yeah.
They want to see that you can think critically, connect the dots, and make sound clinical judgments.
You're right. It's about being a problem solver, not just a walking textbook.
Exactly.
But before we move on to management strategies, I'd love to circle back to a couple of other conditions you mentioned earlier that can sometimes complicate the picture. Sick sinus syndrome and syncope.
Okay.
They seemed a bit mysterious at the time, but now that we've laid the groundwork for understanding tachycardia, I'm hoping those mysteries will unravel a bit more easily.
Okay, great point. Let's start with sick sinus syndrome, or SSS.
Yep.
Remember, it's a condition where the sinus node, the heart's natural pacemaker, isn't working properly.
So it's like the conductor of the orchestra has lost their baton?
Exactly, and as a result, the heart rhythm can become erratic and unpredictable.
Yeah.
It can be too slow, too fast, or a combination of both.
Oh, wow.
Which is called Pachy-Brady syndrome.
Okay.
It can be a bit like a roller coaster ride for the heart.
A roller coaster ride.
Right.
I can imagine that wouldn't be very comfortable.
What are some of the common symptoms people experience with SSS?
Well, some people might not have any symptoms at all,
Really?
especially in the early stages. But as the condition progresses, they might start to experience fatigue, dizziness, lightheadedness, even syncope, which is a temporary loss of consciousness.
So those are pretty general symptoms that could be caused by many things.
Yeah.
How do we pinpoint SSS as the culprit? You're right, those symptoms can be tricky. That's why the ECG is so crucial. It can help us identify those abnormal heart rhythms and pinpoint SSS as the underlying cause.
Okay.
But sometimes we need a more prolonged look using a Holter monitor or even an implantable loop recorder to catch those intermittent rhythm disturbances.
Okay, so the ECG is our starting point. But sometimes we need those extra tools to get the full picture.
Right.
And once we've confirmed SSS, what's the typical management strategy?
Well, the goal of treatment is to regulate the heart rhythm and prevent those episodes of bradycardia or tachycardia that can cause those uncomfortable or even dangerous symptoms.
We need to get that conductor back on track, give them a new baton, so to speak.
Exactly. And the most common way to do that is with a pacemaker.
Okay.
It's like giving the heart a reliable external conductor to keep the beats steady.
Wow, that's amazing technology.
Yeah.
So it's like a little electrical backup system for the heart.
Yeah.
And are there cases where medications are used in addition to a pacemaker for managing SSS?
Yes, sometimes medications are needed to help control the heart rate, prevent certain types of arrhythmias, or address underlying conditions that might be contributing to the SSS.
Right.
It really depends on the individual patient and the specifics of their case.
Right, it's all about personalized medicine.
Exactly.
Tailoring the treatment to the individual's needs and circumstances.
Yes.
Now, what about syncope? We've mentioned it a few times.
Okay.
And it sounds like it could be a real head scratcher.
It can.
It's not a condition in itself,
No.
but rather a symptom.
You got it. Syncope is a transient loss of consciousness, often described as fainting or passing out.
Yeah.
It's caused by a sudden drop in blood flow to the brain. And there's a long list of potential culprits.
So it's like a power outage in the brain.
A perfect analogy.
And we need to figure out what's causing the short circuit.
And yes, the challenge with syncope is figuring out what's triggering those temporary power outages.
Right.
Some causes are benign, like vasovagal syncope, where a trigger like seeing blood or standing up too quickly causes a sudden drop in blood pressure and heart rate, leading to fainting. But other causes can be much more serious, like heart rhythm disorders, including tachycardia.
So tachycardia can sometimes lead to syncope if it disrupts the heart's pumping ability enough to cause a significant drop in blood pressure.
Precisely. And that's why it's so crucial to take syncope seriously and investigate it thoroughly. We need to rule out those potentially life-threatening causes, especially in older adults or people with underlying medical conditions.
Okay, so syncope is a red flag. A signal if something needs attention.
Yes.
And how do we approach a patient who presents with syncope? Where do we even begin?
The first step, as with most things in medicine, is taking a detailed history.
Okay.
We need to understand the circumstances surrounding the syncope episode. Was there any warning? What were they doing when it happened?
Right.
What position were they in?
Yeah.
Any triggers like standing up quickly or seeing blood?
Right.
And of course, we need to dig into their medical history.
Right.
Any medications they're taking and any family history of syncope or heart problems.
So we're looking for any clues that might point us toward a specific cause.
Yeah.
Any patterns or red flags that might guide our investigation?
Exactly. The physical exam is also crucial.
Okay.
We're checking their vital signs, listening to their heart and lungs, looking for any signs of neurological problems, and assessing their overall health.
Right. We're looking for anything out of the ordinary, any subtle hints that might help us solve the mystery.
Yeah.
And I'm guessing the ECG plays a starring role here as well.
You bet the ECG can help us identify any underlying heart rhythm abnormalities that might be contributing to the syncope.
Right.
And depending on the suspected cause, we might order additional tests, like a tilt table test to evaluate for neurocardiogenic syncope, an echocardiogram to assess the heart structure and function, or even a neurological workup to rule out any problems in the brain or nervous system.
It's like assembling a puzzle piece by piece until we have a clear picture of what's causing those fainting spells.
That's a great way to put it. It's all about gathering information, connecting the dots, and making those informed clinical decisions.
And speaking of informed decisions, I think we're ready to move on to the management side of things.
Okay.
We've explored the causes and diagnostic approaches for tachycardia, SSS, and syncope.
Yes.
Now it's time to put on our treatment hats and figure out how to address these conditions, effectively ready for round 2.
I'm ready when you are. Let's dive into the world of tachycardia management.
Welcome back to the deep dive. We've journeyed through the world of tachycardia, explored its causes, and learned how to pinpoint the culprits behind those rapid heartbeats. Now it's time to shift gears and talk about treatment. It's one thing to diagnose these conditions, but knowing how to effectively manage them is where the rubber meets the road.
You're absolutely right. And just like with diagnosis, our management approach for tachycardia depends heavily on the specific type we're dealing with and the underlying cause. It's about tailoring our strategy to each individual patient.
Personalized medicine at its finest. Let's start with PSVT, paroxysmal supraventricular tachycardia. We talked about how sometimes it's triggered by simple things like stress or caffeine. Are those cases where lifestyle modifications might be enough to keep things under control?
Absolutely. For some people, simply avoiding those triggers like cutting back on caffeine or finding healthy ways to manage stress can significantly reduce the frequency and severity of their PSVT episodes.
So it's like taking a preventative approach, minimizing those external factors that can set off those electrical storms in the heart.
Exactly. And for those times when PSVT does strike, we have a few tricks up our sleeves. Remember vagal maneuvers. Those simple techniques like bearing down as if you're having a bowel movement or plunging your face into cold water can sometimes disrupt those reentrant circuits and restore a normal heart rhythm.
Ah, yes, the Valsalva maneuver. I remember learning about that in med school. It seems almost too simple, but it can be surprisingly effective.
It can, and if those maneuvers don't do the trick, we often turn to adenosine.
Okay.
It's a medication that acts very quickly to block the electrical pathways that are causing the rapid heartbeat.
Adenosine, it's like hitting the pause button on the heart's electrical system,
A perfect analogy.
giving it a chance to reset.
And the beauty of adenosine is that it works quickly and is out of the system just as fast, so it's generally very safe to use even in emergency situations.
Okay, so vagal maneuvers and adenosine are our go-to options for acute PSVT episodes.
Often, yes.
But what about long-term management? What if those episodes keep coming back or become more frequent?
That's where medications come into play. Beta blockers and calcium channel blockers are often our first line of defense. They work by slowing down the heart rate and making it less likely for those reentrant circuits to form.
Okay, so they're like traffic calming measures for the heart's electrical system,
Precisely.
preventing those sudden bursts of speed.
And for some people, these medications are all they need to keep their PSVT under control and live a normal, active life.
That's reassuring. But what about those more persistent cases where medications aren't quite cutting it? Is there anything else we can offer those patients?
Absolutely. For people who haven't found relief with medications or who can't tolerate them, for some reason, catheter ablation can be a game changer. It's a minimally invasive procedure where a catheter is threaded into the heart and radiofrequency energy is used to destroy those extra electrical pathways that are causing the trouble.
Wow, so it's like a targeted zap. Eliminating those rogue electrical shortcuts sounds pretty futuristic.
It is, and the success rates for catheter ablation are quite high, often providing a permanent cure for PSVT.
Okay, so we've got a whole toolkit for managing PSVT, from lifestyle modifications to medications to catheter ablation. Now let's switch gears and talk about ventricular tachycardia, or VT. We know it's a more serious condition, often linked to underlying heart disease. Does that mean our treatment approach needs to be more aggressive?
It often does. Remember, with VT, we're not just dealing with a fast heart rate, we're potentially dealing with a life-threatening situation. The heart's ability to pump blood effectively can be compromised, so we need to act swiftly and decisively.
Okay, so time is of the essence. What are our first-line strategies for managing VT, especially in those critical situations where the patient is unstable?
When VT is causing hemodynamic instability, meaning it's affecting the blood pressure and circulation, immediate synchronized cardioversion is the name of the game. We deliver a controlled electrical shock to the heart, essentially hitting the reset button to restore a normal rhythm.
Jesus Christ, cardioversion. It's like jump-starting the heart back into a stable rhythm.
Exactly, and while we're doing that, we're also addressing those underlying causes. If a heart attack is suspected, we might be doing an emergency angioplasty to open up those blocked arteries. If an electrolyte imbalance is the culprit, we'll correct that as quickly as possible.
So it's a two-pronged approach, addressing the immediate threat of the arrhythmia, while also tackling those underlying factors that might be contributing to it.
You got it. And for long-term management of VT, especially for those at high risk of sudden cardiac death, an implantable cardioverter defibrillator, or ICD, is often the go-to choice.
ICDs, those are the amazing devices that continuously monitor the heart rhythm and deliver a shock if they detect a life-threatening arrhythmia, right?
That's right. Think of them as tiny guardians, always on the lookout for any electrical mischief in the heart. They can literally be lifesavers for those who are vulnerable to those dangerous ventricular arrhythmias.
Okay, so we've covered the key management strategies for both PSVT and VT. Before we wrap up, are there any general principles or pearls of wisdom you'd like to share with our listeners about managing tachycardia? Anything that might help them ace those tricky MCCQE questions?
Absolutely. First and foremost, remember that every patient is unique. What works for one person might not work for another. We need to tailor our approach to the individual, considering their specific circumstances, their medical history, their preferences, and their overall health. It's about personalized medicine, not cookie-cutter solutions.
Right. It's about seeing the patient as a whole person, not just a set of symptoms or ECG findings.
Exactly. And another crucial point is to always be thinking about the underlying cause. Is it a simple trigger that can be addressed with lifestyle modifications? Is there an underlying heart condition that needs to be managed? Or is it something else entirely? By identifying and addressing the root cause, we can often prevent those tachycardia episodes from happening in the first place.
Okay, so personalize the approach and address the root cause. Any other gems you want to share?
One more, remember, that managing tachycardia is often a team effort. We might be collaborating with cardiologists, electrophysiologists, primary care physicians, nurses, pharmacists, and other healthcare professionals. It's about working together to provide the best possible care for our patients.
That makes a lot of sense. It's not a solo mission. It's a team sport.
Well, I have to say, this deep dive into tachycardia has been incredibly illuminating. I feel like I've gained a much deeper understanding of these conditions, from the intricacies of those electrical circuits to the nuances of diagnosis and management.
I'm so glad you found it valuable, and to our listeners, remember, the MCCQE is challenging, but with solid preparation and a deep understanding of core concepts like tachycardia, you can absolutely conquer it. Well said. And remember, this is just one step in your journey toward becoming skilled and compassionate physicians. Keep learning, keep practicing, and never stop asking questions. And as always, this podcast is for informational purposes only and is not a substitute for professional medical advice. Always consult a qualified healthcare provider for any health concerns or before making any decisions related to your health or treatment.
Thanks for joining us on the Deep Dive.
See you next time.